ring light, so you can ask her. All right, I think we're waiting for a few more folks to come in. We have quite the crowd here today. All right, a couple more. All right, so did we already go live?
Yes.
Excellent. All right, so welcome everyone. This is the budget hearing for the Subcommittee on Health and Social Services of Appropriations. Today we're going to hear two budgets. We're going to hear the budget of the Department of Housing and Community Development, and then hear the budget of the 3 health regulatory commissions under the Department of Health. Just as a reminder, before we move forward, we are live both on Zoom and on YouTube. So that means that anything that is said or typed in the comments is both being broadcast and is subject to open meeting rules and Public Information Act requests. So what we're going to do is we're going to start, as always, with the analyst report for the individual departments. We will then move to questions for the analyst. After that, we will move to the department's report and response, followed by questions from the committee members. And then if there are any members of the public signed up to testify in person, we will move to them and then open that up to questions as well. If there are folks signed up to testify from the public, they will be limited to 2 minutes of testimony. Everyone else obviously will have as much time as they need to complete their reports. So with that, I want to welcome everyone, and we will start with the analyst report for the Department of Housing and Community Development, and we will start with Emily Haskell's and her report. So Emily, please take it away.
Thank you. My name is Emily Haskell, and I'll be presenting the operating budget analysis for the Department of Housing and Community Development. In the budget summary on page 1, you can see DHCD's fiscal 2023 allowance decreases by nearly 55% to $440 million. This is primarily due to about $250 million of local fiscal recovery funds from the American Rescue Plan in each of fiscal 2021 and 2022 that are passed through DHCD's budget to local jurisdictions. In addition, significant federal funds from the American Rescue Plan for rental assistance and homeowner assistance are not yet reflected in DHCD's fiscal 2023 allowance. Excluding COVID-19 relief, the allowance is fairly level with the current year appropriation, increasing by 0.5%. General funds decreased by a little less than $5 million in the fiscal 2023 allowance. That's because while there is an increase of $5 million in general funds for DHCD's Homelessness Solutions Program, that's offset by the $10 million proposed deficiency for fiscal 2022 for neighborhood safety grants. This new program is part of the governor's Refund the Police initiative, and the fiscal 2022 deficiency is the first of 3 years of funding announced, although there is no funding in the fiscal 2023 allowance, with the next 2 installments expected instead in fiscal 2024 and 2025. The program will provide grants for facility or business district improvements such as surveillance tools, traffic management, or renovating spaces to draw regular visitors. Another new program beginning in fiscal 2022 is Project Restore, which provides 2 types of grants to businesses opening or expanding in vacant spaces: a property assistance grant of up to $30,000 to cover rent, mortgage, or other property expenses, and a business operations grant of up to $250,000. The program is funded with federal funds from the American Rescue Plan, with $25 million announced for fiscal 2022, but not yet added to the appropriation, and then level funded at $25 million in the fiscal 2023 allowance. DHCD made the first awards under the program in December, as shown in Exhibit 2, totaling $11.4 million to 144 businesses, mostly in the retail sector. House Bill 414 and Senate Bill 393 would establish the Project Restore program in statute, and DLS recommends making the $25 million in funding for the program in fiscal 2023 contingent on this legislation. The first issue in this analysis relates to the Emergency Rental Assistance Program, or ERAP, which is transitioning from the first round of $400 million to the second round of $350 million. As you can see in Exhibit 5, ERAP funding for both rounds is split between DHCD as well as direct allocations to the 8 largest local jurisdictions. DHCD distributed most of its $258 million to all 24 local jurisdictions and recently allocated its second round of $204 million, as shown in Exhibit 6. In addition to providing additional funds to local programs, DHCD allocated $5.4 million for legal services as part of the Access to Counsel and Evictions program, $7 million for rapid rehousing, and $3 million for the Baltimore Regional Housing Partnership to assist housing choice voucher tenants. DHCD is also holding $10 million in reserve to distribute later to counties that have been slow to spend their first round of funding, as well as a little over $50 million as an additional reserve to allocate later. Exhibit 7 on page 17 shows the expenditures from the first round of the program by grantee, with the top bar representing DHCD's portion of the funding. Overall, ERAP's first round has provided $212 million in assistance to 33,000 households as of November. The chart also shows that DHCD had an expenditure ratio of 47% for its ERAP 1 funds in November, which exceeded Treasury's target of 40% for that month. 5 of the 8 direct allocation jurisdictions have started to use their second round of funding as well, totaling $5.5 million as of November. And I believe that's up to a little over $8.5 million as of December. Montgomery and Prince George's counties closed for applications in December. Prince George's County has received applications in excess of all available funds from both rounds, while Montgomery County is assessing its current application pool and planning to reopen applications with more targeted eligibility. Exhibit 8 shows failure to pay rent cases and evictions over time. Although still below pre-pandemic levels, mostly due to courts restricted operations as well as to rental assistance, nearly 7,000 households were still evicted in calendar 2021. Next, the second issue in the analysis is Homeowner Assistance Fund, which was created through the American Rescue Plan to provide relief to homeowners at risk of displacement. Maryland received nearly $250 million for the program, all administered by DHCD. Exhibit 9 shows DHCD's plan for allocating these funds, with 77% going to grant and loan programs for low-income households. Applications for those programs opened in December. In addition, $10 million will go toward the whole home weatherization program to address critical energy and health and safety issues that could lead to homeowner displacement. The fiscal 2022 working appropriation includes $98.5 million for the program, including $67 million in PAYGO funds in the capital budget, while the fiscal 2023 allowance does not include any funding for the Homeowner Assistance Fund at this time. Half funds can be used through September 2025, and DLS has asked DHCD to comment on the anticipated timeline for spending the remaining $150 million in funding that hasn't been appropriated yet. Exhibit 10 shows the status of foreclosures in Maryland. Per executive order, the Office of the Commissioner of Financial Regulation did not accept notices of intent to foreclose from April 2020 to June 2021. The CARES Act also offered forbearance of up to 1 year and placed a moratorium on foreclosures for homeowners with federally backed mortgages. And President Biden later extended that forbearance period for an additional 6 months and also extended the foreclosure moratorium through June 2021. As you can see, since then, notices of intent and notices of foreclosure have started to increase, but are still below pre-pandemic levels. The third and final issue in the analysis is related to broadband, which, as you all know, has seen its funding greatly expanded due to federal legislation. The state has allocated $400 million from the American Rescue Plan for broadband programs across the fiscal 2021 to 2023 budgets. And DHCD is also expected to receive at least $100 million from the Infrastructure Investment and Jobs Act. The fiscal 2023 allowance includes $171.2 million in PAYGO federal funds in the dedicated purpose account for broadband. And in fiscal 2022, there's a negative deficiency in the dedicated purpose account to shift some funds to fiscal 2023, but there is still $108 million remaining in the account for broadband in fiscal 2022, as well as $90 million in DHC's operating and capital budgets in fiscal 2022. In addition to the increase in funding, DHCD's broadband programs have also expanded in scope, with Chapter 74 of 2021 renaming the Office of Rural Broadband to the Office of Statewide Broadband, and expanding its responsibilities to include developing a statewide plan, collecting and publishing additional data, and promoting digital inclusion. Exhibit 11 shows all the different broadband programs DHCD is administering, many of which are new in the current year. I'm just going to highlight a few programs. The first is Connect Maryland on the first line. This program is not new. It's the largest component of DHCD's broadband programs and funds the construction of new networks to large unserved areas of the state. The fiscal 2022 application window for this program recently closed with over $250 million in requests, although these requests have not yet been reviewed. DHCD expects to announce the awards this April, and depending on the amount awarded, may decide not to open a separate round of applications in fiscal 2023. On the third line, you can see a new program to provide service to residents of public housing with $45 million provided in fiscal 2022. This funding will be awarded to local jurisdictions and is expected to open for applications this month or next. Down near the bottom of the page, you can see there's $45 million allocated for a monthly benefit to subsidize households' broadband bills, as well as $30 million for a new device subsidy program. These funds are in DHCD's operating budget. DHCD is currently serving over 30,000 households with a monthly benefit, which provides a subsidy of $15 per month on top of the federal benefit of $50 that was established by the Consolidated Appropriations Act. The device subsidy program is in development with a procurement for devices expected soon. This exhibit continues onto the next page. DHCD will provide $2 million for digital inclusion grants to nonprofits or local jurisdictions and $5 million to provide community-based networks for service to low-income households. Applications for both programs opened recently since the analysis was written and are open through March 15th. The bottom portion of this chart shows the sources of funds for all of the above programs, with the vast majority of funds coming from the American Rescue Plan, as I mentioned. Exhibit 13 shows what's coming down the line from the Infrastructure Investment and Jobs Act for broadband. The largest pot of money is the Broadband Equity, Access, and Deployment Program, or BEAD, which has a $100 million state minimum for each state and will primarily fund larger infrastructure projects. The next program is the State Digital Equity Capacity Grant, which has a state minimum of $1.5 million annually. The program will include an initial planning grant for states to develop plans to ensure internet access for disadvantaged populations. The next few programs are competitive grant programs for both digital inclusion and infrastructure projects. And the last program is the federal monthly subsidy I mentioned earlier. The Infrastructure and Jobs Act made this benefit permanent and reduced the monthly amount from $50 to $30. Lastly, Exhibit 14 is trying to get at the need for broadband programs across the state, reflecting both lack of infrastructure as well as other access issues. It shows a rough map of the state with the percent of households with no internet access based on results of the American Community Survey. Chapter 74 charged the Office of Statewide Broadband with creating a statewide plan by July 1st of this year to work toward ensuring all Marylanders have access to affordable and reliable broadband by 2026. The office is working with Salisbury University and the Eastern Shore Regional GIS Cooperative to develop the plan, as well as completing the mapping needed to understand the needs across the state. These maps are expected to be available later this year. Finally, this page shows the DLS recommendation to make funding for Project Restore contingent on legislation. And with that, I'd be happy to answer any questions.
Thank you, Emily. Does the committee have any questions for the analyst? Okay, seeing none, we'll move to the department and introduce Secretary Ken Holt and his team. My agenda, Mr. Secretary, is showing a whole bunch of people signed up. So why don't you go ahead and introduce your team for us and whoever's here, and then go ahead and get into your testimony.
Yeah, well, maybe I could ask the folks to go around the table and introduce themselves. I'm off-site and I really don't see who is on with us. So Robin, can you orchestrate that?
Sure. Good afternoon. I'm Robin Chaconis from the Department of Housing and Community Development. I'm the Chief of Staff. So Secretary Holt and I will be the primary responders, I think, today, but we have other members of our team. We have Deputy Secretary McAvoy, Assistant Secretary Carol Gilbert, CDA Director Greg Hare, and we have the Office of Statewide Broadband Director, Rick Gordon, on with us today too. And I think before Secretary Holt responds to the specific questions, we do have one report requirement that the department is required to present to this committee today. So if you'll bear with us for 1 minute, I'd like to turn it over to Stuart Campbell, who I believe is on, and he can give you an overview of our Community Services Block Grant Program. Stuart, are you on?
Yes, I am.
Great.
Thank you, Robin. Good afternoon, Mr. Chairman and members of the committee. As Robin indicated, my name is Stuart Campbell. I'm the Director of Community Services Programs at DHCD. Per federal statute, every 2 years, the department, as the lead agency for the Community Services Block Grant, is required to participate in a legislative hearing where members of the legislature are briefed on the status of the CSBG program. The program was initially created as part of the War on Poverty by President Lyndon Baines Johnson through the Economic Opportunity Act of 1964. However, it has evolved over the years to become the block grant program that it is today, although alleviating poverty has always been at the heart of its mission. The state of Maryland receives approximately $10 million annually, and by law, 90% of those funds must be awarded by formula to the 17 community action agencies, or CAAs in the state. 5% is used for administrative purposes and the remaining 5% for discretionary awards. Just very quickly, the 17 community action agencies cover the entire state of Maryland and are federally recognized for their role in addressing poverty within their specific geographic communities. The services provided by CAAs include housing, food pantries, shelter, Head Start, rental assistance, job training, healthcare, and much more. There's an old saying that if you've seen one community action agency, you've seen one community action agency because they have a wide breadth of services. In federal fiscal year 2020, CAAs were served 254,345 individuals, of whom almost 83,000 were children. 32% of those families were below the federal poverty level, while 20% of those families were below the severe poverty level. The CSBG program also leverages other federal, state, local, and philanthropic dollars. For every dollar awarded through CSBG in 2020, community action agencies leveraged another 14, resulting in over $144 million in non-CSBG funding leveraged. Additional details are included in the report submitted to the committee, and I'm happy to take any questions that members of the committee may have.
Thank you for that. Anyone else presenting?
Thank you, Stuart. Secretary Holt, do you want to respond to the two questions from the analyst?
Absolutely. Thank you. I'd like to thank Emily and Chairman Resnick. She's done a tremendous job analyzing our department. We had a lot of activity in the past fiscal year, as is apparent with this budget briefing. The two questions that she asked, one related to our project Restore and tying that budget, the $25 million, to the House bill that's been introduced. And we respectfully do not support that recommendation. We think that there's no need to have it contingent on passage of the bill. For the simple fact is that it's going to be funded with the ARPA federal appropriation, and it's unnecessary to make it contingent. We also are committed to following the terms and conditions of the legislation, and we will do that. The second matter related to sort of the timeline for deploying the Homeownership Assistance Fund. And as Emily had pointed out, in fiscal 22, we expect roughly 99 million to be deployed. The following fiscal years, in 23, 100 million, in 24, 48 million, and in 25, the remaining $2 million. So that basically summarizes our response. And again, we look forward to answering any questions. We're very grateful for your attention and for Emily's good work.
I also would just like to add quickly, the department also included in our response document a number of program investment maps for fiscal year 21 activity. I would encourage all of the committee members to take a look at all the great work that the department's been engaged in for the last year. And if you have any questions on any of those programs or maps, we could answer those as well.
Great. Are there any questions? Seeing Delegate Valentino Smith.
Thank you. And thank you, Mr. Chairman. I know you'll ask some other line of questions on the rental assistance program. I just wanted to note 3 areas. Secretary Holt, thank you. I can't, it's like I'm looking for you in one of these squares. There you are. Secretary Holt, thank you. I just wanted to acknowledge one thing, which was on page 10, as the House Chair for the Joint Committee on Ending Homelessness, the increase in the allocations of funds on the homelessness. Thank you. And to commend Stuart Campbell, who has just been an exemplary person and part of your department with respect to the work he does with our Joint Committee on Ending Homelessness. So that was number 1. On page 26 of the document, it talks about the broadband awards by jurisdiction. And I don't, I have to be a little parochial. I don't see Prince George's County on that yet. On the next page where it shows, or page 28, it shows about % of households with no internet access. Prince George's County has 10%. So it may be something offline you can meet with me or me and some of the representatives from the county to figure out how we missed getting some of those awards, given the high % of households we have without internet access.
Well, I think Rick Gordon would be available to address that concern. And Rick?
Certainly, and Delegate Valentino Smith, at this time, Prince George's County has not applied for any grants from us. We are in discussions with a couple of ISP or internet service providers who are interested in tackling some of the unserved areas. And once we get those discussions a little further along, then we'll bring Prince George's County government into the discussions to make sure that everybody's on board with what we're looking at.
Well, thank you. And I appreciate the honesty of the answer and that they did not apply. So unfortunate, and I'll hope to get you and the county together. I guess, Mr. Chairman, if you don't mind, the final question or request would be to Secretary Holt. I know Senator Benson's been in touch with you, and I know our county's been in touch with you, that we are just completely out of money. And you did provide an extra round of federal money. But if you have any other suggestions with respect to what you can do so we can reopen the applications, it would be helpful given the significant need in our county.
Well, we clearly expect to provide additional funding for Prince George's County. We have a variety of reserves that we're going to be tapping into. And prior to a decision about ERAP 2, where we've basically got a $60 million reserve set aside, we will be making an announcement shortly, and Prince George's County will be receiving some additional funding. There are 3 fast spending counties that we're about to announce some additional support for. So I believe that we're very appreciative of all the good work that's been carried out in Prince George's County, and we're going to follow through with some additional funding for that program.
Thank you, Mr. Secretary. Thank you, Mr. Chairman.
Thank you. Let's move to Delegate Young.
Thank you, Mr. Chairman. 2 questions, if I may, and one I'm hoping is quick. You'd mentioned some of the maps that you'd like us to take a look at. I just want to reference the JCR report from December 23rd. At the end, it had talked about maps that were required to be made, or the maps that you're referring to, the ones that were required from last year that was referenced in the JCR report from December. As that it said that there's in the works to create the maps that were required relating to broadband access.
Yeah.
Just want to make sure that that's
That's a great question. We're still in the procurement process, and we will be getting the services under contract probably in the next few weeks. So I think the mapping should be completed by sometime this summer. That's for the that was a broadband requirement.
Yep.
Yeah.
Yep. Sometime this summer. Okay. Got it. So then, yeah, the maps that you're referring to don't meet the JCR, the language at the end of the JCR.
Two totally separate types of maps.
Okay. Just concerned we're for future federal funding. I mean, you know how important it is. Just trying to make sure that we have a accurate.
Yeah, we're just as anxious for those maps. Yeah.
Absolutely. Sure.
Yeah.
So the second question, if I may, Mr. Chairman, there was also legislation last year about the appraisal gap and creating applications for folks to apply. My understanding is that there hasn't been an application created. There's just 2 pilot programs being funded, but that's separate from what was required in HB 1239 that passed last year. There are nonprofits, they're trying to apply for some of these opportunities and they haven't been able to do so. And that there has not been any applications created for this appraisal gap. That was legislation that was passed last year. Is any information on that or anything you can provide us?
Yeah, we were very responsive. Governor Hogan provided $10 million to address the appraisal gap problem. And we've established 2 pilot programs, as you pointed out, one in Baltimore City, one on the Eastern Shore in Cambridge. And we basically have a desire to understand how to best formulate a program that can be ongoing and sustainable over time. We received no appropriation to fund this. So other than the governor's initiative, there's been no funding to support this over the long term. So we felt that it would be very important rather to create a program with no funding attached to it, to utilize the governor's $10 million in a very effective way in a rural as well as an urban setting and understand how to best provide the funding to sort of close that gap. You know, it's called appraisal gap. The way I look at it is pretty simple. We want to get people into single family home ownership. If you're in an area where the prices are pretty depressed and the cost of either rehab or new construction is significantly higher than what the market will bear for houses in that area, that creates a gap. So in order for us to get people to acquire homes, we are providing an additional supplement, in many cases between $30,000 and let's say $80,000 of added money to go in to enable somebody to purchase at the market and yet to have the extra money to pay for what is either the rehab or new construction costs. So we want to see how this program works in these 2 areas. Once we learn how to best operate it and how to deliver the best sort of results, I think then, we're clearly going to continue the program. We have a strong desire. We think it's a model. What we're building right now is a model for the nation because there are very few programs that incentivize home ownership in the way that we're approaching it.
So I appreciate the response, Mr. Secretary. My concern is that the appraisal gap isn't something new, and I know that you're aware of that. I'm not trying to belittle that point. What I'm trying to find out is that, well, you've created 2 pilot programs to address something that was tried to be addressed through legislation last year. You've created 2 pilot programs, but then haven't complied with the bill that was passed into law, which is creating the application process and regulations that these nonprofits would need in order to benefit and also help close the appraisal gap. So I guess I'm trying to just, right now on the books, there's a requirement to create this application. And instead, like you said, there wasn't funding related to it, but there was funding that you've now used to create 2 pilot programs. Why hasn't the application been created?
What's the point of creating an application for a program that effectively has no funding? So we will create the application once we determine the results from these 2 pilots. There will be an application process, but it's premature right now.
Gotcha. It'd be good to communicate that to some of the folks that are waiting to to know that on the back end of this, that's the intent. Because up to this point, it was put in because of the need and precedent for.
Clearly the intent. We supported the bill. We support the concept profoundly. We just wanted to set up a program to determine how it works effectively. Then there will be an application process. And I sure hope there'll be some ongoing funding that will provide adequate money to support what is a very necessary augmentation for areas that are distressed and where the market basically is not attracting enough market value in the houses. And we're probably going to have nearly 100 houses that will be either renovated or newly constructed in these two regions. And we will have some related facade improvements to create not just sort of this nuclear response in a very small area within Johnston Square in Baltimore City and Pine Street in Cambridge. Around that area, we will begin to improve the neighborhood with extra facade improvement money so that there'll be a transition in the market values in those communities.
Sure. Understood. And I look forward to paying attention, working with you, and I hope the disparity study that was also required is going to be involved in your standing up of those two pilot programs. Thank you.
Good deal. Thank you. Look forward to it too.
Thank you. Delegate Henson.
Thank you, Mr. Chair. And I apologize, sorry, for my technical issues. I had turned my camera off because I'm having some internet issues. So I apologize preemptively if any of this lags behind. Please just ask me and I will jump back in and repeat anything that's not transmitted. Mr. Secretary, I would be remiss if I didn't just touch on the last point that was being discussed before asking my question. You mentioned restoring the market value in some of these communities that have suffered from appraisal gaps. These are absolutely choices and decisions and longstanding discrimination that has resulted in properties being undervalued, whether it be through implicit biases that exist or any sort of intentional conduct. But we're not just discussing an issue of market value, because there can be homes that have, you know, similar features and characteristics that are treated very differently when it comes to appraising and attaching value to the property. So I just wanted to state that before I ask my question. My question is what we, a portion of the budget that we adopted last year, and the department in your many roles takes on being compliance monitor and contract manager for several of our HUD properties that exist here. We asked the department to create residents in those properties could reach out to the department and lodge any complaints that they had and be a part of that process of compliance and management. And I'd like to ask for an update on the department creating that interface between the residents and the property.
Well, that's a wonderful question. I do think that we're very focused on customer service. And I think our credit assurance division has established very strong relationships with all of the property managers that we serve to make sure that the properties are in good condition, and if there are any tenant issues, that they're addressed promptly. If Greg Hare is available, maybe Greg, you could address this. If there's been specific systems established in response to what the delegate has stated. I do know, delegate, that we are, very, very focused on strong interaction with our property managers and with our tenants, and to make sure that all of the facilities are absolutely compliant. Sometimes there's confusion around what properties we have responsibility for and what properties are basically public housing, which we do not have the responsibility for oversight. So, Greg, are you available?
Hey, good afternoon, Secretary Holton, Delegate Henson. I guess in response to that, I do believe the department responded with the report as it relates to how we address these concerns. I think, and it is a current path where they're routed through our customer service department or through our Office of Public Information. and it goes to the assigned portfolio manager in our division of credit assurance. And so that is the current process, but we are looking to expand our software platform through our division of credit assurance to assist us with the overall asset management of these properties, but also how we handle customer complaints. And so we thought that the current process was satisfactory until that longer enterprise system was put into place, which we anticipate really in the coming weeks or months.
Follow up with just a comment, Mr. Chair. Please keep the committee the status of that. It was in session 21 that we for the report so we could better understand the relationship between DHCD, subsidized communities, and then last session 2020 for the report. Then last session 21, we asked the department after reviewing the report and seeing the gap that existed there between the tenants at the properties and their ability to impact those reports and their properties being deemed compliant. We asked for the process to be created for that interface with the tenant. And it sounds like from Mr. Hare's comment that you are on the road to creating that software so that there is an access point, but we are very interested in following up and making sure that that opportunity gets realized. Thank you.
Well, I can assure you that we are pursuing software. There's software that I'm very interested in where sort of separate kiosks can be installed in facilities, in affordable facilities, where tenants can go in and verify their income, which is required on an annual basis, but it would give them access to sharing information or raising concerns with our Division of Credit Assurance. I'd like to get, and I don't think that we can get them in 100% of all of the managed properties that we have, but in the majority of the managed properties, I would like to install these kiosks where our residents can privately and easily access our department to share information and to provide the required compliance data that we seek every year. So I think that is the best vehicle to do this. And as Greg pointed out, we are in the process of looking into a procurement to secure dozens of these kiosks. And does that answer your question? Any other thoughts?
It does. Thank you, Mr. Secretary. Thank you, Mr. Chairman.
Thank you. I have a couple of questions to follow up with as well. I know, Mr. Secretary, you mentioned the ERAP funds a little bit in your discussion. I wanted to, like my vice chair, get a little parochial, specifically dealing with Montgomery County. It is my understanding that the county feels that in their allocation of ERAP funding that they were not provided as much as they had anticipated or felt was appropriate. So my first question dealing with that program is, can you articulate the formula that was being used to make those distributions?
Well, I don't know that I can thoroughly articulate the formula, but there is an Urban Institute index that evaluates a variety of census tract data, demographic data, income data that we used in ERAP 1 as well as ERAP 2. I think that was somewhat sort of a guiding compass for us. It wasn't 100% conclusive because we had information from the federal government that we were evaluating as well. We knew, where the highest spenders would be, sort of those 8 large counties that were more urbanized. I can tell you that the distribution of the money has been extremely effective. We've had many communications with Montgomery County to the point where I received a letter from the council. I received a letter from the head of the housing authority. We had a Zoom call together. We have effectively resolved the concern by identifying an additional $8 million to provide to Montgomery County. And there is probably going to be more evaluation of the ERAP 2 reserve that has been set aside, which is $50 million. And that will be reallocated across the fast spenders to some extent. We're allowed to use it for affordable housing construction. So we have all the pressures from the emergency rental assistance. We have all the pressures from the need to construct more affordable housing. And we're trying to balance those pressures. But I can tell you that in response to Montgomery County, they will be receiving $8 million more in the very near future as a result of accessing a reserve set aside. And, it's not a matter of squeaky wheel. It's a matter of prudently being responsive to those fast spending counties. We've identified a few of them, and we will reallocate some reserve money, and Montgomery County is getting a very large percentage of that reallocation.
Well, I appreciate that. So my second question deals with timing. Do you know when that 8 million is?
It's immediate.
Immediately. Okay, sounds
Immediate.
good. And the remainder of that $50 million reserve fund, do you know
So
what the timeline is on that?
What I'm describing as far as this very near term and immediate resolution does not relate to the $50 million.
Perfect. That's great.
Yeah, that's a longer term. When I say longer term, I'm talking about over the next 3 weeks, 4 weeks of internal evaluation, how we sort of balance ERAP 2 against demand, against the whole multifamily construction component. And I think probably in the next 3 weeks, we'll come to a formal decision that will be posted. We have had sort of a baseline understanding, which is what created the initial agitation from Montgomery County and other counties as they looked at sort of those preliminary allocations that we had established. But we're going to look at everything. We had a Zoom call this morning with our team, and I can assure you that within the next few weeks, we'll have a final decision about that. Everybody will be fairly treated. We believe, once you understand how the formulas were established and how the money has been spent, how Montgomery County and other counties use their direct allocation, I think you'll realize that we were very fair and very accurate in how we established the allocations.
I appreciate that. Thank you so much for the answer. And I know my folks are listening, so hopefully they've gotten their answer as well.
Be happy.
Yeah. Any other questions for the department? All right, seeing none, I want to thank the Department of Housing and Community Development on their testimony. We're going to move to public testimony, and let me pull up my list. Had it up, and then I took it down. All right, sounds good. So we're going to call up Kaylee Locklear from the Maryland Retailers Association, Carrie Samus from Prince Anne Main Street, Karen Norman from Downtown Frederick Partnership, and Jay Mishi from the city of Taneytown. I don't know. I know that's a panel, and I don't know who wants to go first. So whoever wants to go first, please take it away, and then we'll go to the second panel after you are complete.
Thank you, Mr. Chairman and honorable members of the committee. Kaylee Locklear here on behalf of the Maryland Retailers Association. It's a pleasure to come before you all today to support the Main Street Improvement Program funding increase. That's in DHCD's budget for our historic designated small business epicenters throughout the state of Maryland. I do have with me today 3 of the Main Street executive directors to share with you a little bit more about their Main Streets and how important this funding is. But for a little bit of background, Main Street Maryland is a comprehensive downtown revitalization program that was created in 1998 by DHCD. The mission of the program is to accelerate the economic progress and revitalization of Maryland's traditional main streets and neighborhoods. And for some more perspective, there are well over 6,000 businesses that are located in 41 designated Main Street Maryland communities. The primary objective of the Main Street approach is to foster economic development and these states' core communities, preserving local historic and cultural resources while supporting small businesses and promoting new investment and business development. Using a competitive process, Main Street Maryland selects communities which have made a commitment to succeed and then provides them with resources to improve the economy, appearance, and image of their traditional downtown business districts. I'm glad to go into specific details about what exactly grants can be used for or some specific economic impact numbers if the committee would like. But as I mentioned earlier, with me, I have 3 directors from Frederick, Princess Anne, and Taneytown, just to talk about where some of the funding has gone and for you to all hear that firsthand. So thank you for your support over all of these years of this important program. We urge you to continue supporting this funding. Thank you.
Ms. Samus?
Yes. Good afternoon, Chairman Resnick and honorable delegates. Thank you for allowing us the opportunity to provide testimony today. I'm Carrie Samus. I'm the Main Street Manager for the town of Princess Anne in Somerset County, Maryland. Princess Anne's been part of the Main Street program since 2008. It was originally housed by the town and run by a volunteer committee. However, in 2015, we received our nonprofit status as a 501c3. Ours is a partnership between the town, the University of Maryland Eastern Shore, county tourism, economic development directors, historic preservation organizations, merchants, of course, downtown, our Chamber of Commerce, and residents. We're fortunate to receive Main Street improvement funding, and we leverage that funding to garner additional support for the program. On average, we managed to triple the state's investment with local support and private dollars by at least 3 times, although last year was an exception because we were able to secure nearly $300,000 in funding to assist our businesses. Our town, our historic town, is home to approximately 3,500 residents. And when the University of Maryland Eastern Shore is in session, our population doubles. So I've been with Main Street Princess Anne for about 5 years now. Since that time, we've diversified our funding and our district occupancy rate has continued to grow. Last year, as I mentioned, we secured $300,000 in additional funding specifically for COVID relief and recovery efforts and revitalization downtown. Our Main Street program has been instrumental in connecting businesses and residents in need throughout the pandemic. We're proud to report that none of our businesses closed permanently, and we were able to assist 4 new businesses that chose to open in the district, which is significant for a town of our size. I just wanted to offer a quick concrete example of how the program works. And one of our successful businesses downtown, Pew's Patient Care Services, opened less than a year before COVID hit, and they started with 5 employees. They now have over 50 employees. COVID relief funding has been critical to their operation. We were also able to help them secure personal protective equipment and additional grants specifically to support Black-owned businesses and help them develop additional technical skills and acquire new tech equipment. Since that time, the owner, Linnell Fletcher Pugh, has invested in 2 additional businesses in our Main Street district. So it's been a great partnership for us. We also just signed an MOU with UMES, establishing a new entrepreneurship and economic development program and an official partnership between the university and our Main Street program. So we're super excited about that. And I know I only have a couple minutes,
I need you to wrap up.
Yep. So just sending you some muskrat love from Princess Anne. We are the town that drops a muskrat for New Year's Eve and spread lots of muskrat love during the month of February. So we have lots of work to do still and very much appreciate your support. Thank you.
Thank you. You drive a live muskrat?
No, it's a taxidermied muskrat, and he's very fancy. He wears a silk cape and a top hat, and yeah, it's a fantastic New Year's Eve, very memorable. I would encourage you to come.
I did get a little concerned for a second, but thank you for clearing that up. All right, Ms. Norman, your turn. Please go ahead.
Good afternoon. Thank you, Chairman Resnick and honorable delegates. I'm Karen Norman, and I serve as the Executive Director of Downtown Frederick Partnership. And I'm obviously testifying in support of increased funding for the Main Street Improvement Grant Program. The partnership is an implementing organization for the Main Street program in downtown Frederick. Our downtown is home to more than 250 retail, restaurant, craft beverage, and personal service businesses. Of those 250 businesses, 99% are independently owned. While the pandemic will have lasting impacts, the partnership is thrilled that our business participation in PPP was higher than the state average, and we now have more businesses than we did in March 2020. The partnership produces 40 events each year, all designed to bring locals and visitors to shop and dine in downtown Frederick. We have used state funding to offer grants for facade improvement, capital improvements to retail interiors, fire suppression, and due to some very specific pandemic-related funding, offered operating support to 177 of our businesses. During the pandemic, the partnership assisted our businesses with employee recruitment, driving more than 11,300 people to our online jobs board, a 30% increase over the prior year. The Main Street Improvement Grant provides a key resource to support the partnership's overall efforts. As one example, grant funding has enabled the partnership to learn more about the economic impact of our events. With MIP funding, we learned that nearly 30,000 people attended our February 2020 pre-pandemic First Saturday, the largest First Saturday event of the year. On average, at that event, each person spent $49, representing more than $1 million in downtown spending on that day alone. Increased Main Street Improvement Grant funding will help the partnership to increase our impact in downtown Frederick, and I encourage you to support this proposal. Thank you.
Thank you, Mr. Mishi.
Thank you, Chairman Resnick, honorable delegates. I'm the Economic Development Director and Main Street Manager in Taneytown in northwestern Carroll County. Our Main Street district is home to 24 businesses, each locally owned and operated. They include a bed and breakfast, pottery painting establishment, antique wood reclamation, a dance studio, a women's clothing boutique, a bakery, and a gunsmith, among others. As of today, we have 7 storefronts that are available to host additional small businesses. One of the projects that we have to encourage entrepreneurs to join us is a video series called Why I Do Business in Main Street, Taneytown. These 2 to 4 minute videos funded by DHCD grants encourage different kinds of people to recognize themselves in our current business owners and to contact us about pursuing their dream business. The Main Street Improvement Program grants also allowed us to create our new neighbor-friendly folder, a folder filled with coupons from our downtown businesses that we mail to each new home buyer in Taneytown. We had additional projects lined up for fiscal 22, but our grant request could only be funded at about 40% of what we asked. With the additional funds included in the executive budget request, we hope to roll out a new mobile app-based tour of Main Street Taneytown, highlighting both our historic assets and our businesses. We'll integrate that with new historical markers on our buildings. With increased funding, we'll also be able to invest in new pole banners for the 47 lampposts in our Main Street. At every turn, the increased funding that the governor has requested will help us to keep investing in our Main Street districts and giving a boost to the brave business people who pick Main Street as the home for their business. Thank you.
Thank you. Any questions for this panel from the committee members? Okay, seeing none, thank you all very much. We appreciate your testimony. I was under the impression that there is a second panel, but it is actually just written testimony from Habitat for Humanity, not oral. So that concludes the budget hearing for the Department of Housing and Community Development. We will now move to the budget for the health regulatory commissions, the 3 health regulatory commissions under the Department of Health. And we will start with the budget analysis from Andrew Garrison. Andrew, take it away.
Thank you, Mr. Chair, and good afternoon.
Mr. Chairman, I'm sorry to interrupt.
Did I miss somebody?
We have a Claudia Wilson Randall who actually also wanted to testify orally.
Yeah, I did sign up, but thank you so much. I appreciate it.
I'm sorry, Mr. Chairman.
Thank you. No, I appreciate that. Thank you for catching
I appreciate it. Not sure how I can come off of mute and dive in, but thank you so much. I appreciate it. I'm going to
please go ahead.
Sure. I'm just going to dive right in and I'll try to be quick. but I did want to chime in on the Department of Housing and Community Development's budget. My name is Claudia Wilson Randall. I'm the Executive Director of the Community Development Network of Maryland, and I appreciate the opportunity to testify to members of the Health and Social Services Subcommittee. The Community Development Network is the voice for Maryland's community development sector, and we serve nearly 200 member organizations. Our focus is on affordable housing developers, housing counseling agencies, and community-based nonprofits across the state of Maryland. And as I just want to make a few brief points about the operating budget. I really appreciate the opportunity to follow the Main Street panel because I don't have to talk about Main Street, but we're very excited to see that budget increase and to see small businesses across the state supported, and also to see that that Main Street program for organizations to be able to thrive with professional staff and leadership. I think that's just a really important piece of the work that the Main Street managers have been able to do, that they're no longer considered all volunteer organizations, that they have professional staff who are focused on the needs of the businesses in those commercial districts. So I think that's really an important piece of the Main Street program. So I just want to make a few points, and I'm one of the concerns I want to raise is about operating funds for the Baltimore Regional Neighborhood Initiative, which everybody refers to as Bernie. And what we're seeing is that the increase in capital funds for that program has gone up, but the operating funds to deploy those capital funds has not gone up correspondingly. So CDN was recommending that currently the Bernie capital budget is at $12 million, and we'd like to see the operating dollars for that funding to be $1.2 million, or 10% of the capital allocation. And the reason we're suggesting that is because it's very difficult for the organizations, particularly in Baltimore City, to deploy that kind of capital. It's Baltimore, it's regional, so it's Baltimore City as well as Baltimore County. It's hard for them to deploy that kind of capital without operating funds. And that area is also the region which has struggled the most during the pandemic. So the city of Baltimore had a number of organizations that were not paid for more than 18 months due to administrative barriers, due to the pandemic, people being out. So that meant people were doing the work in the most troubled communities throughout the region and not getting paid and not being reimbursed. So this Bernie program really could be a lifeline for those organizations. In addition, they took on affordable housing, community-based development work, and they're just not, if they're not able to fund the staff to actually do the project and execute to spend the capital dollars, it makes those projects impossible. So I just want to recognize that. And I would also, the other point that I would make about that is it particularly impacts communities of color and leaders of color, because they are less likely to have operating capital, philanthropic commitment, as well as less likely to have lines of credit. And so it just makes the work in the most needed areas the hardest by far. So just want to make that point to the subcommittee. I also wanted to make another point about statewide broadband. And I just want to say that I hope that the legislative body continues to hold the department and local jurisdictions responsible in the expansion of broadband, because I don't think market-based solutions are going to fix this problem. We need to make sure that it's a priority, that getting folks connected who are not connected also is connected to other programs. So for example, the emergency rental assistance could have come with broadband, or, but connecting programs becomes really important, because it's the same people that we're talking about who are not connected, so I just would hope that we find, I don't think this is always something government is very good at, but we need to find ways for the programs for homeowner assistance and broadband assistance to be connected, literally and figuratively. So with that, I appreciate your time, and thank you for the staff member for realizing that I had signed up to orally testify. Thank you, everybody.
Thank you. And again, I apologize for missing you on my sheet. Are there any questions for Ms. Wilson-Randall? All right, seeing none, thank you again for your testimony. We appreciate it. And we're going to move now to the Health Regulatory Commission budget with Andrew Garrison. Andrew, please take it away.
Thank you, Mr. Chair, once again, and good afternoon again to yourself as well as members of the subcommittee. In front of your screens now, you should be seeing the operating budget for the Health Regulatory Commissions. Of course, these commissions are budgeted together, but are independent commissions. We have the Maryland Healthcare Commission, or the MHCC, the Health Services Cost Review Commission, or the HSCRC, and the Community Health Resources Commission, or the CHRC. Our acronyms we're going to be using a lot here. I also do want to highlight that the Prescription Drug Affordability Board is budgeted here as well. They have their separate budget code, and we've included them here as they were previously receiving funding in part or operating support through the Maryland, through the MHCC. And so they are reflected in these overall numbers as well. But first, what we're seeing in this increase here, about a $70 million increase, is actually driven by 2 new grant programs that are reflected in the Community Health Resource Commission. And we're going to talk about those a little bit more in depth later on. We've also separated out the uncompensated care fund. That's a large dollar amount here. And those dollars flow through the HSCRC in terms of balancing out uncompensated care from hospitals with a higher share of it, and to a lower share of it. But broadly, it doesn't have a huge effect on the operating budget here. And actually what we have broken out here is kind of that overview of the expenditures and showing how from a dollar standpoint, from the state dollars, really a fairly small amount of this budget is in the operating side of things, only 32%, a little bit less than a third, with some of those larger grant programs as well broken out. And so looking at those operating dollars, that smaller third, we've broken that out here. Again, in that we have about half of it committed to other funding or grants for other programs that we've broken out on the far left-hand side of the screen here. And then from the administrative side, the 2 largest commissions from an operating budget standpoint are the HSCRC and the MHCC. Those commissions from their special fund each collectively contribute about, between the 2 of them, $1.2 million to the Maryland Primary Care Program, MDPCP. We'll be talking about them a little bit later on too. And I've broken out the Prescription Drug Affordability Board for you there again as well. And from the administrative expenses side of things, the CHRC is the smaller budgets here. Looking at the changes in the budget, what we see here again is those 2 new grant programs coming in from the CHRC towards the middle of your screen. And jumping into that right away, what we've shown you here on Exhibit 4 is the projected expenditures for the CHRC over the next couple of years. And so there's a few things I want to highlight here. First, those blue bars that you see that go all the way back to fiscal 19, that is sort of the traditional, the standard operating grants that CHRC has done. As you guys know, they fund safety net providers throughout the state, often for newer or kind of startup costs. It's a less, perhaps sometimes a little bit more innovative program, someone that needs a little bit of funding to get a program started. And those are those blue bars there. They've also been able to provide some additional grants making. The Relief Act provided them with some dollars to fund DDA providers. Those are the red bar that you see in 21. And then again, here in 23, we see new money coming into this budget. First is the Maryland Consortium on Coordinated Community Supports. That is $50 million for this year, and it grows pretty quickly into those out years. This is a Blueprint initiative, and it is funded through the Blueprint Fund. And then we also have the HERC grants. Those are the Health Equity Resource Communities. And we have those for the next 3 years. Additionally, there was funding that was supposed to be provided as a pathways to HERC, to this HERC program in 22. That is yet to be reflected in the budget. And so we are asking the department to comment on the availability of that. And then also, again, looking at, by the time we get to fiscal 26, the only funding that's currently programmed for this budget is going to be through those consortium grants. And the operating and traditional expenditures are currently scheduled to no longer be budgeted in 24. Right now, the fiscal 23 and 24 dollar amounts are through the reinsurance fund, which I spoke to you all about a few weeks ago now, and the exchanges budget, where previously it was funded with the Care First premium tax credit exemption. And so we are also asking the department to comment on the availability of funding for those traditional grants for the CHRC in those out years beyond 24. Next, because we do have the HSCRC in this budget, of course, they have a role in the hospital financing and system here in the state, and certainly Maryland's unique financing system. And we wanted to really focus on how the Maryland hospitals responded and how some of the revenue support and flexibility that was able to be provided by the HSCRC impacted Maryland hospitals during the COVID pandemic. So first, in Exhibit 5, what we've done is we've pulled admissions into Maryland hospitals, as well as then revenues across there. And as you can see, admissions have taken a bit of a hit and still have yet to recover, while revenues due to Maryland's unique financing system has actually been able to maintain pretty consistent, and in fact has in some instances been above where it was in prior levels. And looking at specifically COVID-related admissions into the hospitals, we see that at certain points, the share of COVID admissions was never really significant enough to bring overall admissions kind of back up to the traditional volume levels that Maryland hospitals experience. Of course, this data is just for COVID positive admissions that came into hospitals. In the data that we pulled from the HSCRC, they were able to provide people with COVID-like symptoms or COVID exposure. So certainly there was a lot of treatment and also any sort of exterior treatment outside of a hospital doors that happened wouldn't be captured in this budget. But we did think it was interesting to reflect sort of the volume impact that COVID positive admissions may have had on those hospitals. And then additionally, what we also thought was interesting when looking specifically at COVID cases and COVID related charges is how they compared to traditional hospital admissions and expenditures. So in the first two columns, we have charges related to a particular payer type, and then admissions as it relates to them. And then when we look over at the COVID positive side, we see that the folks who are on Medicare had a greater share of admissions than they did traditionally under prior admissions, suggesting that the folks who did end up getting hospitalized for COVID or being captured in this data were likely a little bit older because they were in that Medicare population. And that was actually taken from a admission standpoint, really at the expense of those folks on Medicaid. So the folks on Medicaid seem to make up a smaller share of those admissions. And then kind of tying all that together, what we have here in Exhibit 9 is really focused on some of the dollars and the revenue side of things from the hospital picture. What we're reflecting here is a sort of an estimated loss that might have occurred under a more traditional hospital financing system. And those are those red bars. And we can see that the Maryland hospitals were able to be supported not only by federal action through the Provider Relief Fund, but also some of the flexibility that the global budgeting system does have, and really allowing for stability within the hospital financing structure during what would have otherwise been a really unpredictable and difficult time, particularly again from the dollars. This doesn't necessarily capture any increase in operating expenses from staffing needs, or if the workflow within a hospital had to be changed. This is really looking at sort of volumes and charges that would have been related to the pandemic in particular, because as we know, this was a really difficult time, and Maryland's system in particular allowed some stability for the hospital system. And we are asking for a report. We are recommending committee narrative requesting a report specifically on the relation that the Maryland model has had on providing some of the stability to hospitals during the pandemic. And the last thing I do want to touch on is the total cost of care model. What we've continued to see in the second year now of the model is Maryland being able to meet all of its goals through CMS as outlined under the model. And we have more detail on that in this report. But the first thing highlighting here is the total savings to the Medicare program and the department and the state's ability to continue to carry those savings over into the out years, making the future goals a little bit more attainable when it comes to savings. However, there is a slight concern about the growth rate of Maryland hospital spend when compared to the nation. It's the guardrail is the term that we use throughout this report. And that is, of course, because, once again, of Maryland's unique system in terms of finance, we're able to keep some of the hospital revenues and stability and charges stable compared to other hospitals and elsewhere in the country that are more based directly on admissions. And so because of our system, it put us at a little bit of risk from that guardrail. We are asking the HSCRC to comment on that. However, so far, some of the data that they're seeing thus far is a little bit more encouraging than it was a few months ago, and this certainly began to look like a concern. Last thing, as when we do talk about total cost of care, we also talk about the Maryland Primary Care Program. And for the last 2 years now, you all have asked for an evaluation of this report, of this program in particular, specifically looking at if it is able to cause some savings to the state to its total cost of care goals. We're actually starting to see some of that savings in the most recent report that was submitted for 2020. It's fairly modest. And of course, 2020 was a very weird year when it came to costs within the healthcare system, given it was in the midst of the pandemic. And so we are once again making a recommendation for that continued reporting. We found it really valuable to have that information. And additionally, you all included a request into this last year, specifically looking at the racial diversity. And so we're showing that on Exhibit 12 as to how that shakes out. The Maryland Primary Care Program is on that outer ring, and this is the individuals enrolled in the program, not necessarily the providers. We don't have that information available to us, but it does skew a little bit less racially diverse than the rest of the state. And the other item to highlight on the primary care program is the care management fees. And the state has some sort of outcome-based credits, and with the total cost of care model, there are benefits to the state for having broader population health goals as well. And so in this particular instance of the evaluation, we are also asking to include recommending to include a portion of that discussion on how the primary care program has assisted with some of the broader population health goals that the state has under the total cost of care model. Again, the two recommendations we have are the COVID-19 reporting, specifically on the Maryland model, and that primary care program evaluation. And that concludes my presentation. I'd be happy to take any questions.
Thank you, Andrew. There is a question from Delegate Valentino Smith.
Thank you, Mr. Garrison. And I'm, again, just trying to recall, didn't we talk to the hospitals, and wasn't there going to be a different type of reporting on their not-for-profit status and their community benefit and what they're supposed to be doing with all of that? Was that part of the budget discussions last year, or was that something that we've been, and it may be something that the department HSCRC can answer?
Thank you for the question. We did not request a report on that last year. There is some community benefit reporting that's available through the HSCRC and their broader data collection, but the HSCRC is on here as well, and I sure could update on any other movement that's been occurring there.
Thank you. I couldn't remember if we had kind of officially delved into that or not. We'll work with them on it. Thank you. Thank you, Mr. Chairman.
Thank you. Any other questions for Andrew? All right, seeing none, let's move to the department. With us today, we have Secretary Schrader, also from the department, Andrew York and Amelie Brandenburg. And then from the regulatory commissions, we have Katie Wunderlich from the HSCRC. We have Ben Steffen from MHCC and Mark Luckner from CHRC. So Mr. Secretary, take it away and designate people as appropriate.
Chair Resnick and Vice Chair Valentino Smith and Vice Chair Mark Chang, thank you for having us today, and want to thank the analysts for their report. I'm going to ask Webster Yee to respond to the first two questions in the analyst's report, and then he'll turn it over to Katie Wunderlich, and we'll go down the list from there. So go ahead, Webster.
Thank you very much, Mr. Chair, Madam Vice Chair, Mr. Vice Chair, Webster Yee, Department of Health. With respect to the question about the future availability of funding for CHRC operating grants, current statutory language allows for the premium tax subsidy that has funded CHRC operating grants to continue doing so in fiscal year 25 and beyond. Absent any changes in statute, any future budget decisions regarding the funding levels would be at the discretion of the new administration. With respect to the status of the initial HERC funding authorized by the Relief Act, the Department of Budget and Management has confirmed that Relief Act funds are no longer available to support the HERC program. Instead, the state's ARPA, American Rescue Plan Act award, will be used to support HERC activities in FY 2022. The ARPA support will be brought into the CHRC budget via a planned budget amendment. In addition, we've submitted additional responses in writing, and I'll turn it over to Ms. Wunderlich, the Department of Health joins HSCRC in their responses.
Thank you very much. And thank you, Chair Resnick and members of the subcommittee for having us today. My name is Katie Wunderlich. I'm the Executive Director of the Health Services Cost Review Commission. I do want to first start off by thanking Andrew Garrison for his thoughtful analysis and covering three very important and very different regulatory commissions. That's a lot of information to put into one analysis. I appreciate his work on that. I also want to thank my colleagues, Mark Hoffman, Megan Renfrew, and Hannah Friedman Bell, who helped to compile our response and provide information to Mr. Garrison. Before I forget, Delegate Valentino Smith, I can answer the community benefits question. So when I get to the end, I can circle back to that because I do have an answer for that. I submitted some slides for this presentation. I can go through those quickly if you would like. Really want to make sure that before I get into the specific responses that Mr. Garrison described in his analysis, I just wanted to do a quick overview on the commission and the goals of the model. And I'd be happy to share my screen, or if you all wanted to share, follow along. I'm not quite sure which, Webster, do you know whether they can be, I can share them right now. Let me just go ahead and do that. Is that okay?
We'll defer to June. Ms. Chun?
That'd be fine, Katie, Ms. Wunderlich. Go ahead. Do you have a hosting abilities?
I don't. It's disabled, so that's okay. I'll just talk briefly through some of.
You should have show hosting abilities now.
Okay, thank you.
There you go.
Figured that was easy enough to do. Go ahead.
Okay. Can you see my screen, Mr. Chair?
Yep, we're good.
Okay. So just as a quick overview, I won't take long. I'll make sure that you all have these slides. If you have any questions, please feel free to follow up with me. I do just want to provide a quick overview into the Health Services Cost Review Commission. We are an independent state agency. Our primary and historic responsibility has been to set hospital regulated rates. That's for regulated inpatient and outpatient hospital services. However, with the evolution of the all-payer model and the total cost of care model, which we're now under currently, our role has expanded to lead the state's efforts on those transformation efforts. Our vision is to enhance the quality of healthcare and patient experience, improve population health and health outcomes, and reduce the total cost of care for Marylanders. As a quick glimpse on the structure, we do operate with a 7-member commission, including a chair and a vice chair. Those 7 members have a variety of healthcare, financing, and policy backgrounds. They include health economists, policy scholars, consumer and public members, physicians, and hospital executives, to name a few. So we do have a 7-member commission that governs the HSCRC, holds public meetings, and votes on final policies. To support that commission, we do have 48 full-time staff and 7.5 contractual positions, with a wide expertise, including statisticians, economists, accountants, health policy experts, rate analysts, and others. Collectively, we develop policy ideas, engage with stakeholders, and make recommendations for the public vote. We also, in addition to our full-time staff, we have analytic support from contractors and CRISP, Maryland's Health Information Exchange. Mr. Garrison already covered our FY23 allowance, but just to note that 100% of that FY23 special fund is derived from an assessment on hospital rates. As I mentioned, one of the main responsibilities, in addition to setting rates of the HSCRC, is to have oversight and direction of the Maryland health model. It's really critical to the state's infrastructure and critical to healthcare delivery in Maryland. And in addition to providing the framework for hospital regulated services, the Maryland health model also provides significant benefits to Marylanders. To name a few, the Maryland health model works to improve the quality of life for Marylanders. First and foremost, we're able to invest state and hospital resources into population health and health equity. So the model does allow for to directly address and work on longstanding health disparity and population health metrics in the state. The model also helps to stabilize hospital finances. We'll talk about this a little bit later in the presentation. But even pre-COVID, the GBR that operates under the Maryland health model helps to stabilize hospital finances and ensure access to care in all parts of the state, including rural hospital and rural care. In COVID, it's been especially important to help balance out the finances during the pandemic. It does create cost containment and equity among payers, and then importantly, guarantees equitable funding of uncompensated care, which Mr. Garrison alluded to in his presentation. And that really ensures that all Marylanders, regardless of health insurance coverage, can access care in Maryland, can access any hospital in Maryland. So in Maryland, we do not have public hospitals the same way that they do in other states. And that is directly because of our uncompensated care fund and the mechanism that we have to cover underinsured and uninsured individuals. A couple of components of the Maryland health model that I want to just make sure we touch on, because these are really the HSCRC drives the hospital population-based revenue. That really is the global budgets that hospitals have. Under the total cost of care model, we've expanded to include additional hospital accountability for cost and quality. We are moving forward payment and delivery system reform under the total cost of care model, which fosters care transformation between hospital and non-hospital providers. The Maryland Primary Care Program, which Mr. Garrison alluded to, the HSCRC is not the main driver of that. There is a program management office, but we certainly it's an important and critical component of the total cost of care model. And then finally, the population health and health equity lens that we view everything in the total cost of care model in terms of improving population health and addressing health disparities. 3 of our statewide population health goals include diabetes, opioid addiction, and maternal and child health. So I'm not going to go through, I wanted to give the committee a sense for the kinds of programs that the HSCRC runs that accomplishes the goals of that model, So I'm not going to go through in detail these slides, but please follow up with me if you have questions. The HSCRC runs 4 main quality payment incentive programs, and these are pay for performance programs that are that hospitals are evaluated against, and for which hospitals are accountable for performance in those quality programs. I will note that in our readmission reduction incentive program, we are for the first in the nation to include a disparity measure. We're really excited about that. We're trying to incorporate health disparity and health equity into all of our quality programs and financing programs. And so to include that disparity measures in the readmission program, we are the first in the nation to include that in payment program. This is a snapshot of our statewide integrated health improvement strategy, which is the population health side. It focuses on hospital quality, care transformation, and total population health. Just to give you a sense for some of those population health goals and measures that we have. We do operate a number of special funding programs that helps to support the population health goals. And this is a way that the commission can provide specific and directed funding through the all-payer rate setting system to support partnerships across the care continuum and across the community to address statewide needs. So we have a number of those special funding programs. They were kind of formally called grants, but they really are special funds assessed through hospital rates. And we have a number of them that support diabetes and opioids. We have a number that were specific to COVID-19 and partnerships that were important there to address the COVID-19 pandemic. And then of course, the maternal and child health initiative. This is a snapshot of the care transformation and new model programs. These programs are developed by HSCRC staff and then supported by CRISP. And then finally, just a snapshot of the GBR population and volume adjustments that go into the GBRs to make sure that there are changes to hospital global budgets that reflect where patients are accessing care. So that's just a quick overview of the HSCRC and some of the initiatives that we are involved with. I want to turn now to the specific responses that Mr. Garrison raised. First is on the Maryland Health Model and COVID-19. We had a broad action plan to address COVID-19 and to help to stabilize the hospital delivery system so that hospitals had the finances that they needed in the beginning of the pandemic to address a very uncertain future. And the pandemic really highlighted the benefit of the model and the protections that exist for Maryland hospitals that really are not available in states with fee-for-service reimbursement. So because of our GBR system, we were able to provide financial stability through the pandemic, even as volumes fluctuated, peaked and valleyed. Even through those peaks and valleys, we were able to maintain financial stability. Of course, we are also responsive to consumer and the consumer lens, and so we wanted to make sure we considered federal funding when we were setting those rates so that consumer prices continued to stay reasonable. Mr. Garrison asked about some of the actions that we took to ensure hospital financial and operational stability. I've summarized them here. We are happy to compile that report that Mr. Garrison suggested on the impacts of COVID, both on the short-term and long-term financial stability of hospitals. And so this is kind of a recap of what is also in Mr. Garrison's analysis, but we took a number of regulatory and rate setting actions in 2021 and in the current year as COVID-19 unfortunately has spanned 3 fiscal years, 3 rate years. Another issue that Mr. Garrison raised was the contractual obligations and the status of our model. This slide shows the financial and quality targets that are included in our contract. There are 3 financial targets. One, we have to build up to annual total cost of care savings totaling $300 million annually. That's the first column. The second one is a year-over-year growth test, which is the one that Mr. Garrison flagged in terms of one that has been, that we've been watching closely. There's a third model target, which is to contain the growth of all payer hospital revenue growth per capita. We are not just a Medicare rate setting body, we are an all payer rate setting body, and we want to make sure that we contain the growth on an all payer basis. And then of course, some of those quality targets. Just to provide the committee a snapshot of where we where we were at the end of performance year 2, which was calendar year 2020. We had met all of our targets in calendar year 2020. Calendar year 2021 model performance will not be available and will not be finalized probably till March or April. But what Mr. Garrison flagged was this total cost of care guardrail test. Our guardrail test dictates that the state, Maryland's total cost of care should not grow year over year more than the national growth. It should not grow by more than 1% in any given year, and it should not grow in any amount in 2 consecutive years. And so we've been looking very closely at this total cost of care per capita growth. Right now, this is with data through October 2021, and we are 0.8% above, with growth of 0.8% above the nation. So we are below that 1% threshold, but we were trending very close to that 1% threshold. There are, looks like we are going to be okay on that measure, but certainly will keep the committee apprised. Finally, the outcomes-based credit, and I will wrap up, Mr. Chairman. Mr. Garrison asked about the intersection between the MDPCP and the outcomes-based credit. We do think those are mutually supportive. However, they are do have some separate goals. Our outcomes-based credit is an opportunity that the state has to offset the state's total cost of care with a credit for improvements in population health. Right now we have a diabetes credit, which actually we have a $5 million credit that's coming to us, which is really great, which means that Maryland's performance has been favorable compared to our cohort, our comparison group. So we have prevented more diabetes cases. And in some cases, it is the result of MDPCP. It's the result of the state and MDH leaning in on diabetes. It's a result of a number of initiatives and folks leaning in. But I'd be happy to also provide that update on the outcomes-based credit and the MDPCP evaluation. And I know that was a lot of information. I will stop sharing my screen. I'd be happy to take any questions. In fact, actually, I'd like to just turn it over to Ben Steffen. He will be the next one to present. Thank you very much.
Ben, you're on mute.
I think after nearly 2 years, I would have learned that. Chairman Resnick, members of the committee, I am Ben Steffen, Executive Director of the Maryland Healthcare Commission. I do have a presentation, but I'm not going to go through that today. I'm going to hit a few high points. The Healthcare Commission is chaired by Dr. Andy Pollack. Vice Chair is Randy Sargent from Care First, 13 other members. The Commission's budget for 2023 is set at $35 million. We particularly focus on the 18.8 or so that's focused on our operating funds. Those funds come from revenue provided by 4 industries: hospitals, nursing homes, insurance companies, and healthcare practitioners. The actual share of payment of revenue coming from each is based on an assessment of our workload. Hospitals account for the most, about 39%, followed by insurance carriers. The remaining 35% is about equally split between nursing homes and clinicians. The Healthcare Commission has 4 main priorities. We operate the health facility planning function in the commission. In the state, that is a a service that focuses on healthcare facilities, expansion and modification of their facilities and services. Altogether, 15 chapters exist in the plan, and applicants using those chapters come to us when they seek to expand their capacities. We are responsible for fostering and furthering and expanding health information technology in the state of Maryland. That's principally through adoption of electronic health records. Electronic health records historically have been not interoperable, so there's been a key component in order to make the exchange of healthcare information feasible, and that was through the establishment of state designated health information exchange. That's CRISP. We work closely with the state designated exchange, both from the standpoint of oversight, but also supporting and fostering and explaining the services they provide. Third, we provide a rather extensive suite of quality reporting services on hospitals, nursing homes, hospice, home health agencies, and insurance companies. That has recently been redesigned, in which we have a broad template of quality sites, all within the same framework. I will tell you that's difficult work sometimes, because selling quality in healthcare is not like selling shoes, and that everyone needs them, and oftentimes consumers have a difficult time understanding how they navigate the healthcare system, both from the standpoint of quality and cost. And lastly, we provide strong analytics support from the standpoint of our own studies and research, but also to other state agencies, in particular the HSCRC, the MIA, as well as Medicaid. And recently we've established partnerships with the Maryland Health Benefit Exchange and our newest friends at the Prescription Drug Affordability Board. We are very focused on collaboration through these data systems. Increasingly, we will be pivoting towards other data sources as well as we move towards value-based services. And I think the Commission recognizes the need for greater and greater collaboration. Thus, we work with the Maryland Department of Health in the primary care program. We are instrumental in moving that forward, particularly as we work to modernize and continue to evolve that program consistent with CMMI goals. And as previously mentioned, we are very willing to support the Prescription Drug Affordability Board as they await, revenue from their permanent funding source that was determined in the last session of the legislature. I'll conclude by thanking the committee for indulging me today, and happy to answer any questions.
Okay, why don't we hear from Mr. Luckner first, and then we will move to questions from the committee.
Great. Thank you. Thank you very much, Chairman Resnick. So first, happy Valentine's Day, everybody. It's great to be before your subcommittee and spending a portion of all of our Valentine's Days together. So thank you for that. First, like Ben said, I've got a PowerPoint. You have that. Let's consider that written testimony. I won't read from that today. First, I'd just like to thank the governor for his allowance for fiscal 23, which Mr. Garrison pointed out represents an increase, and I'll talk about that in a minute. And I also want to thank the governor for giving me a great group of 11 commissioners. When I came before you last year, my chair was a person named Elizabeth Chung, who completed her 8 years of service on the commission. And now I have a new chair, who many of you may know, served with you in the legislature for a number of years at Case-Mar. So he's the chair of our commission, and I would just thank the governor for making him our chair. Second, I'd like to thank the members of the subcommittee for your ongoing support. You gave us 2 new responsibilities in the Relief Act last year. The first was to distribute $5 million in DDA infrastructure grants, which we did. And we're pleased that 159 grant awards were issued, and those grants collectively served more than 16,000 individuals. So thank you for that, and we were happy to take on that assignment. The second assignment in the Relief Act was the first year of the Pathways to Health Equity program, which we are right in the middle of. And I'll say as of tomorrow, we will have all-day presentations from 16 applicants, and we'll be issuing grant awards under that RFP tomorrow, and I'm happy to answer any questions about that. So that's an update on the Implementation of Relief Act. And I'm happy to answer any questions after the comments. And then third and finally, as each of us do every year, I'm going to conclude my opening remarks by thanking Mr. Garrison for his outstanding, precise analysis. I wouldn't change one word of his analysis as it relates to our commission. I see that he's smiling, and I'll just also congratulate him on his Bucks for winning the NBA championship last year. We'll see the Bucks and the Sixers this year, how that works out for us. Finally, as Mr. Garrison pointed out, our fiscal 23 budget represents an increase, and I thought members might like to talk a little bit about that, Mr. Chairman. So I'll break that down into three parts. The first is the $8 million that Mr. Garrison said is our regular ongoing statutory responsibility that flows from our authorizing statute. And as Mr. Garrison pointed out, the funding source for that $8 million has changed, going from a portion of the Care First premium exemption to a portion of the state's reinsurance program in 23 and 24. So that starts this next year and then it flows through 24. The second area, which is new, is the Health Equity Resource Community Program, which came from, in part, the Relief Act, and then also the standalone legislation approved by my old committee, your old committee, Delegate Resnick, HGO. Thank you for that. And then the third area is the provision included in the blueprint bill from 2020, which was vetoed and then overridden, that establishes this new consortium on community support partnerships. And under the statute, our commission is asked to help staff that consortium rather, and we're looking forward to that responsibility. And I'll conclude by thanking the governor again for including 5. That's a lot for us because we have 4 PINs right now. So he's allowed us to hire 5 new additional staff to support those new responsibilities. And the first position we're looking to hire is the Health Equity Resource Community Project Director. It's a grade 19 position. The recruitment period closed February 1st, and we were overjoyed by the number of resumes we got. We got over 60 resumes, and we're going through those as we speak, and we look forward to that person starting very soon. So with that, Mr. Chairman, I'll stop, and I'd be happy to respond to any questions as part of the panel for you. Thanks again, and it's good to see you again.
Hi, thank you, everyone. Sorry, please ignore what you heard. I was not on mute, sweetheart. Why don't you go? Thank you. That was awkward. Thank you, everyone. Really appreciate all the testimony and all the information that we received today. Are there any questions for either the department or the executive directors of the commissions? From anyone? Yes, Delegate Valentino Smith, go ahead.
Thank you, Mr. Chairman. Before I start the question, I know Ms. Wonderluck had indicated she was going to answer the question on community benefits. So if we could let her answer that question, then I'll ask a few questions, if you don't mind, Mr. Chair.
Thank you, Madam Delegate. Yes, so the HSCRC was directed by legislation to compile a community benefits an update to our community benefits reporting structure in 2020. And really a couple of things changed there, which was a more direct involvement of the community health needs assessment. So the community health needs assessment is a project that's undertaken with community partners. And so the intent of the legislation was to highlight and connect the work of the community health needs assessment to the community benefit spend. So we spent some time a couple of interims ago working on that in terms of increasing and highlighting the role of the community health needs assessment. I'd be happy to forward you that JCR report that we submitted. I think it was either a JCR or it was in response to legislation, but I'd be happy to forward that to you again.
Thank you. It's always helpful to know I'm not losing my mind. I kind of remembered that we were doing that. So if you could send the report, that would be helpful. So one question that I've always been unable to fully comprehend. You have a community benefit with respect to filing taxes as your not-for-profit status, right? So you've got community benefit there. And then you have community benefit with respect to the philosophy and total cost of care and what you, now do you count the same project in each bucket, or do you have separate community benefit buckets?
So there's only one community benefit report that the hospital is required to do, and we are required, the HSCRC is required to compile all of those reports. They report them to us, we compile them together. And that community benefit report is for the purposes of, in part, explaining and quantifying the investment in the community that offsets the taxes that they don't have to provide as a nonprofit. Now in Maryland, the goals, the financial incentives of the GBR are very much aligned with providing community benefits, because hospitals benefit when their constituency and the patient population in their service area is healthier, and when chronic conditions are managed, when community health needs are addressed, acuity level in the community can stay low. And so there is some alignment between the financial incentives of the GBR and the community benefit. And hospitals do a lot of work around that, around the community benefit spend. But we do want to make sure that that community benefit spend is derived from the needs identified in the community health needs assessment, which again is a collective effort between the hospital and their community partners.
Okay, so thank you for that. So Mr. Chairman, I have about 3, maybe 4 questions. So let's just stay on community benefit for, and these aren't in the priority, but you're on community benefit. So as you know, I am the House Chair of the Joint Committee on Ending Homelessness, and we spent some time the last 2 interims working with the HSCRC and working with the hospitals to try to determine how you're doing your assessment at discharge of who is homeless. And at least at this last interim, the hospitals, we saw more information on there at least being now some appreciation for which hospitals have the highest number of discharges with respect to homelessness. And we wanted to try to encourage the HSCRC and this total cost of care model to do a little bit of focus on its responsibility at discharge for this community. And so we talked, and we knew a lot of pressure was on the model because of COVID and everything, and didn't mandate anything. But we did ask the HSCRC to adopt a revenue for reform policy, or to relook at their revenue for reform policy, to look at the incentives and look at the retained revenue that's kept, and start to express to us what you're specifically doing in those areas where you have a high discharge in a homeless population. So I would ask that that continue to be something that you report to us on, or we continue to have that dialogue on. So have you done anything with respect to that revenue for reform policy or adjusted it?
So thank you so much for that question. We're really proud of the revenue for reform policy development that's happened thus far. As you mentioned, we put a lot of our policy development, our major policy development on hold through COVID because hospital staff were stretched thin and being redeployed. So we did put a hold on implementing the revenue for reform through COVID, but we are looking to bring it back. So what the progress, or what the process would be is we would bring it back as a formal recommendation to the commission. The commission would approve that formal recommendation, and then it would be implemented in a future rate year. So ideally it would start in July in this rate year. However, we have some abnormalities and inconsistencies in the data because of COVID. So we might have to push that until January, but it remains a high priority. And so that revenue for reform will identify and quantify community investments that hospitals make with their GBR dollars. and will safeguard and safe harbor those community investments. And we are pushing for connection to the community health needs assessment, for primary care in underserved areas, for collective actions that help to reduce health disparities and improve population health. So
thank
very
you.
much a priority.
Right, and again, specifically with respect to those communities' availability and your partnership with respect to the housing status, transitional and/or respite housing. So in closing, I would just ask that on this particular topic, you've spent a lot of time explaining all of the data that you have, both you and Mr. Steffen. And it's a little bit clear that you don't have the greatest data, though, on the status of the clients at discharge. And so that you continue to keep being able to talk to us about the housing status of the people that are leaving the hospitals would be very helpful. So the second thing I wanted to talk about, very concerning, you called the Maryland Primary Care Program important and critical. And Mr. Steffen, I think, even referenced the Maryland Primary Care Program. And on page 4 of the analysis and page 5, it talks about the funding that goes into that program. So then on page 20, in response to some concerns that I know I expressed last year, that we really look at the racial makeup of that program, since it is so critical and important. And Exhibit 12 is very concerning. It shows that there is, it looks like to me, a very lopsided participation in that program with respect to our white and Black communities. And it also says that the HSCRC reported the data are not available. Can you help us walk through that Exhibit 12 chart, which shows 72% are white participating in the program and 21% are Black?
Sure. So thank you very much, Madam Delegate, for that question. And I know Secretary Schroeder might want to weigh in here as well. So the MDPCP program, I do believe, is critical and fundamental to improving patients' health at the source at a trusted primary care level. So I do think that it is really important to addressing health needs, including diabetes, which I think can be controlled and addressed through primary care. So absolutely think it's a critical program. The program itself is a CMMI program that Maryland helps to administer. So the payments for it, the reporting flows through CMMI. However, Maryland, on an operational standpoint, is on the ground through the PMO to help the practices to operationalize it in Maryland through the practices.
So part of the JCR report was to include not only the participation and the racial, and it looks to me alarmingly disparate, especially when you talk about diabetes, which we have a higher impact in the Black and Brown communities. And it says that the data is not available because we wanted to know, and maybe this is for the Secretary, the participation rate of minority providers in this program, because there are financial kind of incentives to participating. So can somebody explain why we've got such a disproportionate participation of white versus minorities, and we don't have any data with respect to the participation of minority providers in the program?
So, Delegate, if I could, so I know we've talked about that repeatedly in various groups, either the providers directly or with among the staff. And we've also looked at broadly value-based programs nationally, and the challenges. This is not really an excuse, but I think the evidence, there is this evidence that the participation of minority providers is typically in these value-based programs, which do impart some additional risk, financial risk on practices, is less in Maryland and is less across the country. Secondly, there has been a historic question on the risk adjustment algorithms that oftentimes go into determining rewards that may not completely capture the underlying and baseline disease burden of a population. And sometimes practices, especially practices that have large percentages of minority or low economically deprived patients, are hesitant to go in because they know that the risk adjustment algorithms that in this case of the MDPCP are really devised nationally do not take into account that risk completely, and consequently rewards are not going to be as great. And third, we know this both from Maryland and we know this across the country, that typically minority physicians are more apt to practice in small practices or individual practices, which make it more difficult to participate in value-based programs because, simply put, if you're practicing by yourself or practicing with one other colleague, it becomes very difficult to meet the additional requirements that a value-based program of any sort comes into play. What's really good, and I think wise of the legislature to continue to require this, is the ongoing evaluations, which typically in the science are known as rapid cycle evaluations, where we're gathering data year by year, trying to make mid-course corrections to the extent CMMI will allow us to do, and provides additional insight in the program. Typically, the very scientific and rigidly formal evaluations take 2, 3, 4, 5 years to complete. And it's only well after the program is done that you can really see what happens. These rapid cycle evaluations that you all have wisely required us to take gives you some insights into some of the very problems that we're trying to highlight. The best issue I think we can address is trying to make risk adjustment fairer. And to that regard, in 2022, there's an additional adjustment under the existing program for what's called disparity adjustments based on the area index called the Area Deprivation Index, which allows an adjustment for care management fees for patients that live in lower areas of higher deprivation and themselves are at higher acuity. So I think that's beneficial. It's one of the first times the Area Deprivation Index has been used for this purposes. It's been developed by Amy Kind and her colleagues at the University of Wisconsin. And I think it has a lot of credibility for addressing some of the concerns you have. But I will frankly say we're aware of this. There's more to do. And keep asking us these very questions.
Well, I will conclude because we've got a long day, but I must conclude, Mr. Chairman, with significant on the record concern, again, that these things could take years to correct, and that we are putting in could be a couple $1 million into a program that is clearly rewarding predominantly white, healthier, more affluent patients and physicians. And that money or some money could be quicker and sooner redirected to ensure that we don't see this kind of racial disparity in the communities that need it the most, especially in the value-based things that we've made the decisions to invest in, like diabetes, and I think heart disease and some of the others. I find it extremely concerning that it could take years to correct and that we are perpetuating something with such disparate on its face application. So thank you, Mr. Chairman.
Thank you. Any other question for the commissions? Okay, seeing none, I believe, June, correct me if I'm wrong, I don't believe anyone else has signed up to testify.
Nope.
I don't want to make that mistake again.
Testimony.
All right, sounds good. I think we are all testified out today. I appreciate everyone participating and the information and the questions. With that, we are going to be adjourned. I don't believe we as a subcommittee are meeting again until next Monday, though the Appropriations Committee in various forms will be meeting throughout the week. So thank you, everyone. Appreciate it. See you next Monday for subcommittee. See everybody tomorrow for